Morning and welcome to the 17th meeting of the Health, Social Care and Sport Committee in 2025. I've received apologies for this meeting from Brian Whittle and Elena Whittam, and Stephanie Callaghan is joining us as a substitute. The first item on our agenda is for the committee to agree to take items 5, 6 and 7 in private. Are members agreed? The next item on our agenda is an evidence session on the subject of pandemic preparedness. And I welcome to the committee Professor Sir Gregor Smith, Chief Medical Officer for Scotland, Daniel Kleinberg, Deputy Director, Population Health, Resilience and Protection Division, Scottish Government, and Dr Jim McMenamin, Interim Director of Clinical and Protecting Health, Public Health Scotland. And we'll move straight to questions, and Emma Harper.
Thank you. So, obviously we're a few years down the line from the COVID pandemic, and I'm sure we've all got personal experiences and things that we remember about it and about what could have happened or what could have been done. I myself was a registered nurse during it, given vaccines as well as being an MSP. So I'm interested to know if you can tell us any detail about any progress that has been made in implementing the recommendations from Module 1 of the UK COVID inquiry that the emergency preparedness and resilience structures should be simplified. And I see Dr Gregor nodding here.
So shall I begin, and my colleagues will begin to kind of add to what I'm going to say. As you say, we're now unbelievably just over 5 years on from that moment in time when a pandemic was declared, and the world changed for all of us at that point in time as we sought to combat the effects of COVID-19. And you're right, there has been substantial learning since that time, learning during the pandemic response, but also in the period that afterwards, through statutory inquiries, as you've referred to, but also through other sources as well. And I think it's important to reference those other sources of learning that we've taken during that time as well, starting with the production of the 4 UK CMOs technical report and a substantial body of evidence within that as to how we should technically respond to future threats when they inevitably arise. Moving from that, as I say, we've had in Scotland... Sorry,
Dr Smith, can I get you to move your microphone round towards you a little bit? Thank you.
Maybe I'm on the wrong microphone here. Is that better? Why don't I shuffle along this table just a little bit, and that maybe sits me closer to this microphone. So, as I say, the UK CMO's technical report is one element of learning. The Standing Committee on Pandemic Preparedness has also produced a substantial report with recommendations which have been begun to be implemented. And of course, we have at this moment in time the UK Public Inquiry, which has published Module 1 recommendations as well. I'll turn to my colleague Daniel Kleinberg in a second, and he can begin to kind of speak through some of the work that's been taken forward in relation to that. At a UK level, there is extensive work which has been examining the technical aspects of the response that will be necessary when a future pandemic inevitably arises. And we should think about this as when it arises rather than if it arises, because whether it be in the next year, 5 years or 20 years, we will continue to encounter pathogens with pandemic potential. And we can speak a little bit over the course of this hearing as to the type of pathogens that are most likely to cause that threat. At the moment, there is an update being prepared to the Respiratory Action Plan, looking at the broad range of respiratory pathogens that may have pandemic potential and that we may need to act and provide some sort of technical response to in that time. Work continues on that at a UK level, with Scotland contributing both in a technical and a policy sense, into that piece of work at this moment in time. The Standing Committee has probably been one of the most important pieces of work in the Scottish context over recent times in terms of the development of recommendations for us to consider and then take forward, not least of which is the formation of a Scottish Pandemic Sciences network. And I'm going to pass to Daniel Kleinberg, who can give us a little bit of an update on that just now.
Thanks. Before I go to the Standing Committee, your question was specifically on Module 1 and the Hallett Inquiry recommendations. So if I can start there and come back to that, that would be good. The first thing to say is just we've welcomed in the Scottish Government in full or in principle all of the recommendations, but the 10 recommendations that Hallett makes, some of them fall to the UK Government. So, for example, there's things about simplified structures for civil contingencies, lead government department model in the UK, which we are working closely with the UK Government on. So, but we will wait to see just where they go with that. For the most part, she's talking about things like simplified structures and how to go about that. And I think that's something I recognise. So the government has written back, Kate Forbes as DFM has written back to Baroness Hallett, saying that by the end of the year, and in some cases sooner, we'll make full responses to each of those. The thing I see, as Gregor was alluding to, is already the beginnings of simplified structures. That tends to be in the wider contingency response. I'm very interested in, well, I'm specifically interested in pandemics, but what pandemics do is similar to what some of the other big risks we face would do. So as Gregor was talking about, the Pandemic Disease Capabilities Board, which is a UK structure, but in which we take a full part, has begun to look at future pandemic preparedness specifically. And on that, as Gregor spoke about, there's a respiratory response plan being prepared in draft, which will be, I think, the basis for a more specific response to future respiratory threat. So going back to Hallett again, what Hallett says is too much emphasis was based on a pandemic flu plan. I think that's uncontroversial, that's accepted by everybody. Already what we've done at a UK level is look at different types of pandemic threat. So we now have a respiratory response plan in draft. That will be followed up by plans around, for example, sexually transmitted diseases and the other sources of diseases. So a much broader based planning approach. So in response to Module 1, that's already well underway, but the formal response from the government will follow later in the year, I think.
And just to follow up, I mean, I know there's complexities around planning, whether it's for flu or other potential disease pathogens and that. So are you confident that the simplification process is underway? You've talked about various reports, Module 1, there's the Respiratory Response Plan, the Scottish Pandemic Science one. So there's work obviously underway. So are you confident that that is now in a process of simplification?
And then through to you. Yes, although it's still a really complex environment, so I don't want to give false assurance that it's all very straightforward because it's such a complex thing to respond. In Scotland, there's now a single level cabinet committee, or not cabinet committee, sorry, ministerial group looking at pandemic preparation very specifically. That first met in January of this year. It next meets tomorrow. So that's looking at capabilities assessments within Scotland. Within the UK, it is an improving position as well. So I think we've mapped out the governance better than we did. So yes, and I think having that specific group in pandemics, it adds to the number of groups, but it allows much greater specificity of thinking about and responding to the risk potentially.
I would agree with Daniel's assessment of that there, and I think that it is an improving situation in a necessarily complex area because of the wide range of potential threats that could be faced in this space. But actually having the governance sorted out at the centre of all of this has been a tremendous, I think, step forward in how we do this. I think having a coordinating centre in Scotland, which is now beginning to kind of find its feet and be set up and form, which involves Scottish Government, academia, the public health agencies and actually industry, to how we coordinate the science that sits around about future pandemic response is a big step forward for us as well. So I see the elements forming around about us just now.
Okay, thanks. Thanks, Convener.
Thank you. David Torrance.
Thank you, Convener. Good morning, everyone. Around risk assessment and future planning, further to the findings of the UK COVID Inquiry's Module 1 report, what changes, if any, have been made to the risk assessment process in Scotland to take better account of the specific needs of the Scottish population and who may be vulnerable?
Sorry, I'm happy to start. So we take the risks that we're managing. We're effectively thinking about two risks. One are emerging infectious diseases, and the second are full-scale pandemic diseases. Both of them are described at a UK level with the public-facing document, the National Risk Register. And just to give you a sense of it, that assesses the risk of a future pandemic at between 5 and 25% in the next 5 years. So it's a catastrophic risk if it occurs, and it's a fairly probable risk to occur. So, the methodology that lies behind that is constantly under review. So at the moment it's being looked at again, and that informs how we work with the Scottish preparedness community. So there's previously been a Scottish risk assessment, but in effect, the risk of a pandemic is a global risk. So the articulation of that and the methodology is very similar in both cases. It's how you respond that changes and is local.
So in parallel to that, and Jim may want to come in and add a little bit more to this, but across the UK there is constant horizon scanning of emerging pathogens or disease patterns through the global sharing of data and surveillance mechanisms. I think this is a really important point. The strengthened global surveillance is absolutely key in all of this, and again we may want to kind of go into the role of WHO in relation to that at some point over the course of this hearing today. But that data is then considered at a UK level as well through UK HSA, and risk assessments are made of emerging pathogens. So an example of that might be recent Mpox data from Central Africa and how that might impact on the UK. Also H5N1, keeping a close eye on the way that is crossing from different from avian sources to kind of mammalian sources as well, and how that affects the risk assessment for the UK as well. So beyond what Daniel has said, there's technical assessments of risk as well for individual pathogens, which are fed into that process by UK HSA, of which we're a part as well.
Thank you. Just to add from my perspective in Public Health Scotland, that continual risk assessment process is something that CMO has just outlined, that there's a horizon scanning that is undertaken not just by our own organisation, but by our UK HSA colleagues and also by a number of really expert groups, whether that's World Health Organisation or CDC, or different branches of organisations across the globe. That network and coordination of it is one that has continued to share information about new and emerging threats to allow that risk assessment to be undertaken. I happen to be a member of one of the UK groups that would look at this too from a respiratory pathogen perspective, the UK New and Emerging Respiratory Virus Threat Advisory Group, NERVTAG, and I've been a member of that group since its formation. Groups like that continue to keep a close eye on any emerging threats, and they are inevitably then providing advice to the government of the day, but also sharing that with the devolved administrations about what those threats may be. And to come back to the first question, to also offer some insight there, it's not that any of us are waiting on the recommendations of the UK public inquiry, but rather have just got on with things. It may well be that many of the things that are coming through, either in current or future recommendations, we're already discharging, because the learning of the past had been that we have to take action now, and that for all of what we do, whether that's surveillance or risk assessment and future planning, we then are responding to that by having the additional resource that's been provided to all of the UK agencies to be able to put us in a firm footing, to be able to respond to whatever our bread and butter challenges are today, to ensure that, yes, that we are in a good position to build on that existing infrastructure, to build on that, to prepare for our next challenge. And that includes some of the national exercising, some of which we may wish to hear a little bit more about in the proceedings today.
Thank you. What's been done to ensure a greater focus on preventing the spread of a disease within the pandemic preparedness planning, rather than focus on the impact of a disease? Because a lot of time it's always reactive rather than preparing for it.
So how we prevent the spread of an emerging disease will depend very much on what the disease is and the mechanism by which it transmits. So whether it's a disease, lots of potential pathogens have pandemic potential, but they exert that potential in different ways. Some through the spread through airborne and respiratory routes, some through contact, some through water sources. There's a variety of different means by which these pathogens can act, and therefore how we prevent the spread depends very much on what that mode of spread is. But one of the first points is about learning and understanding the nature of the pathogen itself, whether it's a virus, a bacteria, a fungus, or whatever it is. It's learning, first of all, the characteristics of that individual pathogen to learn by which means it spreads, and therefore how do you begin to take measures which reduce the possibility of that spread. Personal protective equipment remains a very important aspect of that, and maintaining stockpiles in Scotland for up to 12 weeks now of recently respiratory protective equipment is one of the aspects that has changed since the beginning of the last pandemic. But it's that broader understanding of how the pathogen actually exerts its effects and spreads from one individual to another, which will determine then what the kind of response is. So it becomes really key as a disease, a new disease begins to emerge, as to get samples of that particular pathogen, and then to fully understand the process by which it exerts both, as I say, its transmission, but also its impact on the body, the disease effects. Jim may want to say just a little bit more about this because he's an expert in this area.
Thank you. Our capability to detect things is certainly been lifted up a gear now with the advent of the opportunity to look at genetic fragments of any new pathogen. That new frontier of whole genomic sequencing is something which we came to see at the forefront of our COVID response, and it remains certainly at the heart of what we have in capability to identify infections that may prove challenging. But even going beyond that, in the very recent past, we've had a newer branch of that emerging called metagenomics. You can imagine any of us could have travelled anywhere exotically. We could come back with a range of symptoms that mean that we present to any medical service. you might have a normal battery of tests that are done for that place that you've come from, and that they may prove negative. And dependent upon the severity of the illness, that leaves the medical profession scratching their head. The advent of metagenomics and the capability that actually exists on our doorstep because of the MRC Centre for Virus Research in Glasgow has offered us the opportunity to begin to look at these new infections that as yet maybe don't have a name, but that you can identify genetic fragments, so that the identification of those infections for the first time in a population, and in the event that as CMO has just taken us into, that's proving to be such a severe illness and spreading rapidly in the population, and that potentially is therefore a pandemic spread of that infection, that offers us that early and very illustrative first insight into something that we might be able to do about that. We've already used that metagenomics approach in the very recent past, in that children in Scotland were presenting with, at the time, an infection of their liver, something called a hepatitis. And the main thing that at least two of the committee will be aware of, because of their clinical practice, would be that the main way that might present is with these children becoming jaundiced, that they develop a yellowing of their skin, and if you look in their eyes, etc. But this was of such severe presentation that resulted in these children being managed in an intensive care setting in our Scottish paediatric hospitals. The normal battery of tests available for those individuals was testing negative, and that this was then something which was classified as a non A to E hepatitis. It's an illness then that was not yet characterised as what the cause was. But on our doorstep that we had the CVR, along with an additional unit in England, able to look at genetic fragments, and we were able to prove conclusively that this infection presentation was actually a combination of two different viruses, an adenovirus-associated virus, as well as a different virus that the children had. This metagenomic potential that we now then are looking at is our next frontier for what we are trying to do in the development of our capabilities, and that actually offers us a unique insight potentially into what might be rapid identification in the future, communication about that threat, and in the advent of treatments or vaccines, being able to deploy them to treat such a thing.
It's worth saying that in that particular incident that Jim highlights there, that this wasn't these cases of infection in children weren't unique to Scotland. They were seen elsewhere in the UK and indeed across Europe. But actually, it's a real testament to the expertise of the Scottish teams and both the infrastructure and the techniques that have been developed here. There was the Scottish teams that led the identification of the pathogens underlying those infections.
Just add a bit to that as well, and come back to Ms Harper's question a little bit. One of the reasons that we are so keen to get on with finding the pandemic science partnership that you referred to is that use. I started rather grimly by saying there's a 5 to 25% chance of another pandemic. Nobody wants to hear that. And nobody wants to hear it's getting more likely, not less likely, as new technologies, which make these things more likely through potential malicious use, people going into parts of the world as climate instability hits. All of these things are making these things more likely. In our favour is how much the technology moved along and how much investment COVID brought into metagenomics, whole genomic sequencing. We also have water-based epidemiology, so wastewater testing. Our ability to look for these things and to characterise and assess them is, I'm going to say, much better than it was. I'm not an expert in the way that these two are, and especially Jim, but it's moved along a lot. And we've also invested hugely globally in the so-called 100 Days mission, for example, So the use of new technologies around vaccines, the mRNA platform, all of these things, huge amounts of investment so that if and when we find the next one, the chances of being able to respond as swiftly as possible and to prevent the level of harm that you might otherwise see is just greater than it was. But it's always a risk management process.
It's useful to think about that response in terms of a scalable response. That's the really important aspect of this for me, because this could be something which involves the whole country, or it could be outbreaks which are much more localised and involve imported cases from other countries of diseases that we actually, we see on a basis just now. This technology and approach, if facing the right way, allows us that scalable level of response and then be able to identify and manage those cases, whether it be a viral hemorrhagic fever that's already known about, or whether it be disease X, which is yet to be characterised in the future. The important thing is that no matter what, we ensure that we have the infrastructure and the elements here in Scotland to be able to respond to that.
We're getting geeky and excited. Sorry, I'm going to... The centre, the link into the science and the research network in Scotland is huge because Jim mentioned the CVR, the Centre for Virological Research. We have genuinely excellent research community in Scotland around these things. And if you talk to some of them, the next step there is the use of artificial intelligence to be able to characterise how viruses might behave. So you can find something you've not seen before and do in a very short period of time what might have taken years to do. So that's the next technology, I think, that will come in our favour. So whatever is brewing away in a bat cave somewhere in a place that we've never been before, we'll be able to understand how it's likely to behave and respond to that.
Thank you. No further questions, Convener.
Sandesh Gohani.
Thank you. A declaration of interest of practising NHS GP. Sir Gregor, you spoke about global surveillance, and I want to very briefly explore our relationship with the United States of America, given its size and wealth and power. And the Health Secretary, RFK Jr., who has criticised vaccine safety, including saying autism comes from vaccines. So what is our relationship like with the USA?
So, over the course of the pandemic response, very strong relationship was developed with the Centre for Communicable Diseases and CDC and the Centre for Disease Control in the United States, and we had regular meetings with them where we shared data, and that has continued in the post-pandemic period as well. Jim has taken part in many a meeting with me as well. And I think it's fair to say that there was a period, particularly at the beginning of this year, when the sharing of data became, there was less of a flow of data from CDC than we had previously enjoyed, particularly in relation to the very close scrutiny which we undertook with CDC around about the emergence of H5N1 in cattle herds in the US. That's since improved. And you'll see from the CDC website that they're back and sharing data very extensively on that website there as well. So the CDC is a changing organisation just now, and I think we're yet to see how the changes that have been instituted with the new administration in the States will settle down and influence the way CDC interacts with the world outside the United States. My observation would be just now at this stage that it is perhaps not as strong as it used to be, and I think that the withdrawal of the US from the WHO does create a significant gap in our surveillance systems globally, not just in the United States, but actually with the funding that comes with the United States membership of the WHO. I think that there is a risk that global surveillance systems are undermined rather than strengthened as a consequence of that. So it's certainly an area that I have been anxious about, and that I think that the WHO recognises as a potential issue that could develop for the future. Having said that, I am very aware that the WHO continues to take steps both to reform in itself, but also to make sure that as it does that reform in itself, it makes sure that it prioritises actions which allow us that degree of confidence that we need about global surveillance systems. In May at the 78th World Health Assembly, we saw the agreement of the Pandemic Accord and a strengthening of the IHR as part of that as well. The outcome of which I am reassured by to a large extent in terms of the global cooperation that we'll see, particularly around surveillance system and the continued prioritisation of the WHO in global surveillance systems as one of the things that it sees as an absolute must-do.
Dr. Jim and Sir Greg, you both spoke about the excellent work that's been done in Glasgow. You spoke about viral hemorrhagic diseases, metagenomics, and the University of Glasgow that run the lab, with funding streams shifting and ending, are very concerned that they're not able to provide the 24-hour support that they do right now. You know, when someone, when our nurse came back from Africa and we needed instant genomics, they woke up, lab came on, we found the code really quickly and treated the nurse in London. What can we do to make sure that labs like this, which are world-leading, don't lose funding and close?
Again, others may wish to comment that are here with me today, but we are incredibly fortunate with the work that the Centre for Virus Research in University of Glasgow gives us. It's a fascinating place. I had the great privilege of attending a conference hosted at the University of Glasgow on UK pandemic sciences recently, and heard many of the members of the CVR speak at that conference about the work, the really innovative, groundbreaking work that they do. And my very strong view is that that work must be sustainable, and funding streams from a variety of different sources, whether it be from the research environment or from other sources. We must ensure that the CVR is allowed to proceed with the plans that it has in place to continue that viral research.
I wonder if I can also add to that. First, I completely agree with what CMO has just taken us through about that continuing and really very important relationship with the Centre for Disease Control. That's been really very important for us to be able to share information with each other about what are we seeing as any particular emerging issue, whatever the geographical location of those cases. Coming back to the thing that you were just taking us into, I think it would be important that we don't just say that we have, one centre of excellence. Indeed, the whole thrust of having a National Scottish Pandemic Science Partnership is to strengthen that link through with all of the teams who are involved. There's exceptional work that's done, whether that's in the University of Edinburgh, whether that's done in the computing resource that we have, or our mathematics associations with University of Strathclyde or Caledonian University for some of the instant and outbreak issues that we deal with. Incredible technical expertise across the board in all of these settings. It's important then for our strengthening of approach that we ensure that, yes, that we are well connected, we are able to learn from each other, not just here in Scotland, but internationally with what we do. And it's really then an essential feature of things beyond what are our main reasons for existence within Public Health Scotland, where we are, of course, involved with addressing inequalities, preparing for pandemics, and that we have a statutory responsibility for that. But it's relationship building with those who will be involved in assisting us in how we would manage our future problems.
Thank you.
Thanks, Convener. Just thinking about, I don't want to cause shock or alarm to anybody, but I'm thinking about how do the scientists that work with humans and tracing the genomics of pathogens and viruses? How do they work with our veterinarians, for instance? Because, you know, like recently we've had issues of Schmallenberg, blue tongue, foot and mouth in Germany. And, you know, I'm thinking about the zoonotic aspects of avian influenza, which Sir Gregor, you've mentioned already. But how do we how do we work with the other scientists in order to track and trace the potential pathogens from basically ticks, fleas, other wee beasties like that?
Well, first off, I hope it won't surprise you to learn that there's huge cooperation and very rich contact between the medical and the veterinary scientific communities in relation to this. And in fact, I have regular contact with the Chief Vet as well in relation to some of the developments in her world and some of the disease patterns that we see across Scotland as a result of that. And what was very evident to me in the contact that I've had through the scientific networks that have formed round about pandemic control, so the UK Pandemic Sciences Network in particular, the Scottish Pandemic Sciences Network as it begins to form, is that One Health umbrella, where we're looking at the broad biological threats across both the animal world and the human world are taken together. And you're absolutely right, there is a variety of different vectors that we need to consider in that space, whether it be vectors such as mosquitoes or midges or ticks, or whether it be vectors which have an avian or a mammalian source as well. There are a number of different considerations in that space. But I see very close scientific cooperation across that. In fact, I myself have received presentations in relation to some of the changing patterns, particularly of those vector-borne diseases across Europe and within the UK over recent times. I think this is going to be a factor that we need to take much more and closer consideration of as we see the effects of climate change beginning to exert its effect across Europe. Over recent times, we've seen the emergence of some disease in Europe which has gradually spread its hold from southern, more kind of southern basis up into kind of Europe with a dengue fever in both Italy and Spain, and now in the suburbs of Paris even. And I think it's only a matter of time before we see further spread of disease like that as a result of climate change as well. We also see changing patterns of illness in the animal world as well across Europe just now, and that sometimes leads to the emergence of small pockets of disease in humans. Good example of that has been West Nile fever in Germany and in Holland over recent times as well. So these are all things which the scientific community across veterinary medicine and human medicine have very close cooperation with. But Jim may want to say a little bit more.
Thank you. Delighted that you raised this. Last year we made a consultant appointment, Professor Dominic Mellor within Public Health Scotland, who came from the veterinary team there and is our lead for veterinary public health. And that close integration of what we're doing is just one example of why we think that's so important. The CMO just took us into one recent example of why that's important. West Nile virus, as was reported just 2 weeks ago by our UK HSA colleagues, as detected for the first time, admittedly in a sample dating back to 2023, in mosquitoes that were local to Nottingham. So this global issue about climate, sustainability and potential public health impact are critical. Indeed, probably the best epidemiologists I've ever worked with are in the veterinary side. I am particularly mindful of the work of Marta Valenciano, who was a colleague I worked with in EpiConcept. Incredible epidemiologists who we all learn from each other about how do we appropriately investigate and manage any new incident, no matter whether it's starting in an animal population or in humans.
Patrick Harvey.
Thank you, Convener. Good morning to our witnesses. Could I very briefly pick up on one of the points Sandesh Galhani raised before I move on to my own questions about the relationship with the US? One of the things the US administration is threatening to do is to prohibit publicly funded researchers from publishing in respected peer-reviewed journals and potentially to set up alternative journals which look as though they would be guided by the ideology of politicians who've been known to promote conspiracy theories and debunk science. If that happens, if that threat is realised, would you agree that there's a need to re-evaluate US agencies as partners at that point?
I think I would not want to be drawn into speculation about what may or may not happen in the United States just now until we have some firm evidence of actually the approach that's going to be taken by CDC. I know that they're working on various reports just now looking at the patterns of infectious disease that they're seeing just now and the patterns of illness across the country as well, including how vaccine uptake may have impacted in that as well. Until I see some firm evidence of which way CDC is likely to report on these and how they're likely to be particularly peer-reviewed. I think this is an important aspect of the science which is being produced, the provenance of the reports, the data and how that's interpreted, but also how the scientific method has been peer-reviewed as well. I don't think I would want to be drawn in on what approach is likely to be taken.
But if it happens, that judgment would rest with you as CMO rather than with ministers?
Certainly the clinical and scientific community would provide advice to ministers about our view on the veracity of any reports.
I want to move on then. You know, whatever level of technological progress and research progress we have, and there's been some positive and optimistic comments about that, the planning and the preparedness need to be there if we're going to get effective use out of them. And the influenza preparedness strategy was essentially the only game in town before COVID hit. The devolved administration here in Scotland had adopted it, despite having the option to go in a different direction. And the inquiry has found significant flaws with that, not least that it was specific to influenza, and that didn't turn out to be what hit us. Presumably one of the reasons why the strategy was effectively abandoned early on, and the different administrations in the UK went their own ways with new approaches. So the inquiry, I mean, it has noted that there's been some work on various documents since then, but it found that there is still a lack of clarity of how both the problems and the solutions are set out, and it recommended a UK-wide whole system civil emergency strategy. Where are we with implementing that recommendation, both at UK level and under the devolved administration here in Scotland?
I'll maybe pass to Daniel here, who's been quite involved with all of this work.
So some of that comes back to my first answer around Baroness Hallett and the response around that wider civil contingencies. But if we're going into pandemics very specifically, I think one very positive thing that's come out of the last couple of years is exercise Pegasus, which will happen focused around autumn, so anchor days in September, October, November time, which is a Tier 1 UK exercise in which all of the four nations are participating, looking at pandemic preparedness, and it will test itself against a scenario which won't be known before we go into it, or will only be known by those who design it. For me, I think that's a really good opportunity for Scotland to test how it would try and structure itself. And I think there's two things I think about the pandemic flu plan from 2011, which structured, I think it structured quite a lot of what we did in COVID, actually. I don't think it wasn't fundamental to how we designed it, but nor was it abandoned. It creaked and it didn't work, and people have said why. But as we learn what we would do next time, I think two things really stand out. One is nothing in that flu plan envisaged some of the advances in technology, but one of the things it didn't envisage was the use of non-pharmaceutical interventions. So it didn't suggest that we could, using social measures, non-pharmaceutical measures, stop flu in its tracks, which we did for 2 years with COVID. So you didn't see a flu season for 2 years. Now, whether or not we would reach for that again, I don't know, but some of the impacts of flu are so horrific. You know, a pandemic flu which is felt primarily in young people would be a genuinely terrifying prospect, way beyond the fatality rates potentially that we saw with COVID. So thinking through how we would make those decisions is really important. So I'd like to see in Pegasus as test in Scotland, as they will at UK level, what we stand up, a respiratory response plan rather than a flu plan. So it might be a flu. I still think a flu is a big pick for what comes next. So please don't, you know, I don't think any of us would want to denigrate flu planning. But having that variety of response, and I think one of the things we did in Scotland, which we should test again with Pegasus, is the use of what we call the four harms approach. So that's meaning that ministers were taking decisions in COVID not on the basis of just stopping the virus or stopping the disease, but thinking about harm one was how you counteract the virus and the disease it causes. Harm two was pricing in what you might be stopping in health and social care, so the impacts of some of your control measures. Harm three was some of the social impacts of that, for example, and the educational impacts. And harm four was the economic impacts. And that ability to try and make decisions across the full range of the impacts you're having immediately and in the future, I think we need to be testing and putting into our decision-making framework. So that all feels to me like things that we will have in place and test.
Just as you don't want to downplay the importance of flu planning, I don't want to downplay the importance of pandemic planning in isolation, but I'm kind of asking about how it integrates with that wider approach, what's been described as a whole system approach in relation to emergency planning. You know, the planning for a pandemic is very, very important, but it has to be seen as part of a wider understanding of how the country responds to emergencies.
Why don't you come in and expand a wee bit further? There's a little bit that I want to say as well, Mr. Harvey.
Sorry. Thank you. There's definite commonality. So, you know, whatever else you do, health and social care resilience is likely to be a big feature of just about any of the major contingencies that we plan against. A lot of these happen at UK level, so a lot of it's about financial planning, for example. So, I mean, I just agree, and that connection into that wider contingencies world is important. The specificity of pandemics as such, I think you need both. I just think you need to run both in tandem.
So I want to go back to my bit about scalable response, which is really important here, because scalable response, particularly for the NHS, in terms of how it responds to an emerging threat such as this, there are commonalities as to whether that threat is winter surges in respiratory disease or the emergence of a novel pandemic. There is part of that which is about the scale of response, and so working through the resilience mechanisms, and I know that the branch of Scottish Government in Health, EPRR, is currently working at developing new guidance for health in relation to those scalable responses and how we health specific in relation to that. And that's the bit that I wanted to kind of just drill down on just now, because I think that developing that and making sure and ensuring that we have the ability to be able to scale a response, whether it be a malicious threat or attack of some sort, or whether it be a new or emerging infectious disease, that the NHS is then able to respond to that in a way that we would expect. The second aspect of the contingencies work, which I think is really important in the preparation work, I just wanted to say a little bit as well, is about the learning about any emerging disease or pathogen. And I can't emphasise enough the work that has to be done in preparation. Where UK sciences are particularly strong is in the ability to be able to analyse and develop scientific learning about the nature of any pathogen threat, and then as a consequence of that then go on to develop interventions which can address that, whether that be novel tests or whether that be how we use infection vaccines or so forth as well.
I do appreciate these answers. It's inevitable that they're going to have a health focus because of the particular range of witnesses that we've got here, but I'm really asking about the context. Is this happening in the context of work to implement this recommendation for UK and devolved governments to work together to introduce a whole system civil emergency strategy?
Just coming back on that, one of the things that's been agreed and which has been signalled to Baroness Hallett in the Scottish Government's response is that Cabinet will consider biannual papers on whole system civil emergency. So that work is certainly beginning. I'm just not as familiar with it as the pandemic side of it, but yeah, well, underway, I would say, yeah.
And just one additional thing, that the National Scottish Pandemic Science Partnership isn't just looking at what we would do for the hard sciences, you know, what we do for laboratories, etc., what we do for data, but also, just as importantly, from a behavioural perspective, what is it that actually we need to do to keep the trust of our population? What is it that we need to do to ensure that we have potentially some hard things that have to be discussed at the time? How will we address those so that we can see that for Stephen Riker and others, colleagues like that, incredible contribution that they'll be able to make in this sort of format?
I mean, this comes on to what was going to be my final question, Convener. One of the flaws that was identified in the 2011 strategy was the lack of an economic and social dimension to it. And that covers a great deal that's non-medical, that's not specific to a health pandemic, but still very relevant to a health pandemic, would have been relevant 5 years ago. Trust and trusted sources of information in the context of an age of disinformation, very, very important. Community infrastructure, so that people know where they can get help informally and quickly. You know, are we investing in those kind of community organisations and relationships? We haven't been for 15 years or so. As well as, you know, very basic things like homelessness, people having safe, secure, adequate housing. Really, really important to keep people safe in any emergency, but in particular a pandemic. So can you comment on to what extent that connection, beyond the direct medical and public health response to a pandemic, what connection is being made to the social and economic conditions that will enable us to weather a storm as such?
I want to say just a little bit about that first, but then I want to come and say specifically about working with the population in relation to this.
Pandemics exacerbate underlying social and economic inequalities. I think that's just a given. I don't think it's for me to comment on just that wider socio-economic policy. I just don't think it would be. What we do know is that we have a better understanding of how we would support and reach out to vulnerable groups from COVID. I think continuing with that work is really important, but as is some of the learning we took from trusted sources of information. So I agree with what you're saying. It's an important part of where we need to be.
Data. Data is key in all of this, and data was one of our blind spots, particularly at the beginning of the pandemic. It got better as the pandemic response got on, but making sure that we've got the right data that informs us of where the pandemic is particularly likely to have a more severe impact. As Daniel says, every pandemic that we've seen over the ages, back to medieval times, it's those who are most disadvantaged that tend to suffer the worst effects of it. What's interesting now in the retrospective look that we have in terms of how the COVID-19 pandemic impacted on people is that evidence from across Europe identifies that those countries where we were already starting to see challenged trajectories for improving healthy life expectancy, particularly across cardiovascular disease, tended to fare worse than the countries that had been able to maintain the trajectories of health improvement in those areas as well. So creating better health resilience within the population has to be a big target. So how we work with communities to make sure that we're creating healthier communities during this period is absolutely essential. So the work that proceeds on reducing inequalities, therefore, not only has an effect on improving the health of the population, but in the event of the next pandemic will prepare us in a much better way for the impacts of that as well.
From a public health perspective, public health is fundamentally shaped by social context.
That those marginalised or seldom heard individuals in the population are at the heart of what we're trying to do, whether that's in our routine public health offer, but that's just exacerbated, as CMO has just taken us through, whenever we are faced with a pandemic issue. Data is the heart of everything that we then need. Delighted that we've made such significant progress in our capability to link data, because the Scottish population would expect us to be able to say, for interventions that we have, does it work? What is the reduction in hospitalisation? What are the number of lives that are saved by whatever you are trying to do? And it comes back to that other thing which I've just said something about to you, which is that's fundamental to maintaining the trust of the population to bring them with us in any journey that we have in that response.
Thank you very much.
Paul Sweeney.
Thank you. Thank you, Kabir, and thank you very much to the panel for coming in this morning. I think Sir Gregor hinted at the theme of some of my questions, which relates to the Module 1 report highlighting the importance of data and research when responding to a pandemic. Though I also note that the UK inquiry was told by Professor Patrick Vallance that there was a paucity of data, and I think Sir Gregor just echoed that point, and that the UK government and devolved government administrations, in Professor Patrick Vallance's words, were flying more blind than you would wish to. And there's other issues identified around the lack of formal structures for the Office of National Statistics to contribute to preparedness planning, as well as a lack of compatibility in data systems across the 4 UK countries. And in the report, it does identify that this means that despite England, Wales, Scotland, Northern Ireland being at risk of the same health emergency, the data and health systems were so different that they were a barrier to effective preparedness. That's at paragraph 4.75. Just wondered if members of the panel could comment on that weakness that was identified, the paucity of data identified in the UK COVID inquiry, and what work is specifically underway to establish countermeasures to those weaknesses so we have appropriate and reliable data systems across the UK.
I'm going to begin here, and then I'm going to turn to Jim, who will be able to expand a little bit more on some of the specific data sets that we've developed since the pandemic and actually used extensively towards the middle and later stages of the pandemic as well. But in those early stages, you're right, actionable data was difficult to come by in developing a response, partly because in those early stages of any response to an emerging pathogen, there is a learning process to try to determine key aspects such as transmission rates or case fatality rates, and although the UK had good mechanisms by which that information could be derived, none of these mechanisms are particularly rapid and depend on the number of cases that you're actually seeing to be able to develop that information. So that has all been looked at and thoroughly examined as part of the response for, as I say, what is likely to happen the next time. But developing data over the course of the pandemic was a feature which became of paramount importance, and sharing data across countries as well. And you're right, there were points during that pandemic response when data was not directly comparable across the 4 nations because either definitions were used in a slightly different way or the data was collected in a slightly different way. The more we have a confluence of approach in that space, the better. I think the data world in Scotland has progressed significantly since those early days, and even, as I say, during the course of the response to the pandemic, we saw much more sophisticated data systems. Jim will no doubt speak a little bit about a platform which he was extensively involved in called Eve2, which became a really fascinating and trusted source of how, for instance, vaccines were exerting their effect on the population as well. So I am much more confident, but there's more yet to be done. And as part of the Pandemic Sciences Network, one of the really important aspects of their work is going to be to ensure that we have the data platforms and the means identified to be able to collate data and link data. And I think that last aspect is particularly important to ensure that the response the next time is as effective as it can be right across all groups of society. Jim?
I might just add something before we go to Jim, which is, and it comes a bit back to Mr. Harvey's point. So data is one of the subgroups of a future pandemic preparedness group within Scotland I was talking about. But part of what we've learned from colleagues in there is that they've been working very closely with the UK Government's Cabinet Office about the use and sharing of data for emergency preparedness generally, so not just pandemics, because again, a lot of the material is common. So that Memorandum of Understanding is going to be part of an analytical framework, which will be part of signed by Cabinet Office and devolved administrations in the coming weeks. So that idea of using data across different types of crisis and just what you're able to collect and share, it also raises, you need to have this as a conversation with the public, because much of what you would want to know in a pandemic might involve data about people's movements and so on. So how you collect that fairly, decently and transparently is hugely important. So.
Thank you very much. Coming back to what CMO just took us into, it's really important. We're in the city of Edinburgh, and the Edinburgh University Usher Institute were so important for us in what we were able to deliver for the early estimation of antiviral or vaccine effect, Eve2. That actually had its origins back more than a decade ago, in 2010-11, when we thought it would be a good idea to be able to have the capability to link general practice information with hospitalisation data, with vaccination status and the laboratory data around those individuals, along with death data. That approach was then in place and was in a hibernation project that we jointly developed between a predecessor organisation to Public Health Scotland, Health Protection Scotland, in which I was based, and I was one of the folk who then took that through the Ethics Committee for approval at the time. That approach stood us in such good stead in the deployment of the vaccines that we use for COVID, that we were the first country to be able to produce a national estimate of the effectiveness of the vaccination in the first wave. That was critical, I think, and my colleagues in PHS are with me on this, that it was of such critical importance, not just to us about the path out of some of the societal restrictions that we had, being able to demonstrate the effect of a vaccine, but was actually of great utility for not just the rest of the UK, but internationally. It was something which was intensely covered by a number of international reports, whether that was in Washington or New York or elsewhere, where all of that information was something which allowed the world to change its perspective and continued to enforce the usefulness of the vaccines that we had available to us.
I think that's a helpful insight and certainly encouraging in terms of Scotland's underlying data picture, though I suppose I inevitably come back to focus on areas of development. What are we doing to improve the data systems specifically? What projects are being commissioned? And is there a view to how that will be tested? Is there going to be exercises in the pipeline? Is there a timescale for when data systems are likely to be tested in a pandemic exercise simulation in the next few years? And also, what new hibernated studies or existing studies are being developed? It would be good to get a more specific indication of what's underway in light of the learning from the COVID-19 pandemic.
A little bit more about data, then I'll come to Daniel, who'll say a little bit maybe about the exercising aspect of it.
Thank you. I offered you the example of what we did with the EVE2 study. Using a similar approach, we were able for the first time to also do a whole UK study called Coalesce, in which we were then addressing what the CMO just took us into about ensuring that we have data comparability between individual constituent bits of the UK, able to offer insight into how would we undertake such work in the future. I think that's really important and sets the scene for where we are today and what our capabilities are for that, much of which we've also covered in the ambition of what that National Scottish Pandemic Science Partnership will offer, where we're trying to ensure that the data provision and the data flow and the governance, the information governance around that is all in place in advance. And in the event that there are amendments to that, that they can be rapidly implemented to allow that early sharing of information for action.
Just a couple of things to say. One is there is a data strategy within the Scottish Government for health and social care, and that includes a Creating Data for Insights programme. So we've already got Scottish dashboarding for key indicators across health and social care. So developing that further would be already something well in hand. When it comes to exercising, I spoke earlier about the 4 harms approach, and that's what I would expect us to use in Pegasus. And in order for ministers to make decisions, they need the data and the analysis on each of those 4 harms I mentioned earlier. So economic, social, educational data as best you have it at the time. So I expect us to be standing that up and seeing what data sources are online and working well and where those gaps feel like they are when we test that. So I think Pegasus is a really good chance to have a look at that.
Thank you. We are over an hour into our session and we've only just reached the halfway point of our questions. So can I ask members to be concise with their questions and panel members to try and be more precise with their answers. And I go to Stephanie Callaghan. Nope, Ms Callaghan's not online. Oh, she's there.
Sorry, convener, I couldn't unmute there. Apologies. So with the 5% to 25% chance of a new pandemic that's been mentioned already today, learning from past experiences is clearly going to be crucial. So just focusing on the planned autumn exercise, which isn't that far away now, the UK inquiry identified a number of limitations across previous exercises. So I'm wondering if the witnesses can detail how this year's Pegasus exercise will be different from the previous ones, in particular around containment strategies, following up on recommendations and addressing that disproportionate impact that falls on vulnerable people and groups that we've already spoken about.
So I don't know about different, but what Pegasus will do will publish, I think, the learnings from the exercise. The UK has indicated that it wishes to publish, for example, a pandemic strategy, which is informed by the findings from Pegasus. But with all of these things, for me, the really key thing is, once you've identified the lessons, how are we going to implement them, who is going to implement them, and where? I can't really speak about the details of Pegasus, because by nature it's, and beyond that point, the detail of the exercise is only revealed at the point when you you go through it.
I'm wondering how confident are you then that those actions and follow-ups will actually happen, because that's certainly been quite a weakness in the past.
Yeah, so I'm confident that there's a very high level of interest, scrutiny and willingness to learn those lessons. I'm confident that many of the lessons identified in the past are in hand, but what we haven't done is report back on them in a way which I think fully makes that transparent. So I think all of that is likely to be better under Pegasus, because I suspect the level of scrutiny and interest post-COVID is just going to be greater again. And I think the need to learn these lessons is shared, really. So if I say I'm hopeful, I think that's the best I can say at the moment.
And the inquiry report recommended as well that guidance should be kept in a single UK-wide online archive, which would make it much easier from the sharing point of view and the access point of view. So I'm wondering what work's already underway to develop the UK online archive, and is there an expected timeline for completion on that?
Catch the question. I'm sorry, convener, I didn't catch the question from.
Asking about the development of a UK online archive so that data could be shared more effectively.
I'm certainly not aware of a UK data archive or moves towards development of that. Certainly not been involved in any discussions in relation to that.
Could maybe come in. I think you were asking a bit about guidance, or it's a slightly bad line. So one of the things that we're doing under the future pandemic work is looking at guidance. So Public Health Scotland stood up an awful lot of guidance under COVID, where a lot of that is likely to be the sorts of things that would be needed again in future pandemics, but refreshing that, understanding it, placing it into the Scottish context. So one of the challenges of guidance is many of the principles are the same about the disease, but the deployment and the response is very often local. So I know that guidance certainly is something we've got a cell looking at within Scotland.
That's fine. Thank you, convener. I'm aware that it's quite a bad line.
Sandesh Gohani.
Thank you. I'd like to focus on key lessons for future pandemics. And Daniel, you spoke about the up to 25% likelihood of a pandemic in the next 5 years. And I'd like to talk about COVID variant NB1.8.1, dominant strain in China, a huge surge in hospitalisations, more contagious than previous variants, spread to 22 countries, and it accounts for 10% of COVID cases worldwide. Is this something of concern here, is the first question. And the other is, if it is of concern, how prepared are we for this variant?
So I'll start and then I'll bring my colleague Jim McMenamin in relation to this. So MB 1.8.1, something certainly we've been watching for some time and looking to see how cases of this develop. And you're right, some of the statistics that are being reported from China in particular certainly seem to suggest that there has been a rise in respiratory associated hospitalisations in that country just now, and certainly ED presentations also appear to have risen there as well. We're also seeing it in pockets of other aspects of the world as well. I note that some of the states in the United States have issued of advice in relation to this just now. It's not ubiquitous at this point in time. It seems to be fairly localised in terms of where it is exerting its effect. But again, what we're seeing is from a relatively low baseline globally, we're now seeing a rise in cases of COVID that have been associated with hospital infection. There have been some cases in the UK, so we have seen that. And Jim and I had a conversation about it just earlier this morning, and some of the analysis that's currently going on in relation to try to determine just the what is the accurate assessment of any potential impacts of this, particularly in well-vaccinated and exposed populations just now. But Jim may want to say a little bit more about the work that Public Health Scotland are doing in this just now.
Thank you very much. As CMO has just taken us into its early days for what we might see as a consequence of this particular genomic type of COVID. What we have in our surveillance arrangement at the moment is our opportunity to use whole genomic sequencing, which is undertaken on Scottish samples, along with other colleagues in the rest of the UK, to see is this something which is going to be any more than just penny numbers that we currently have of cases? Is it going to become more dominant within the number of different variants that are being reported across the UK population, but in particular here in Scotland? For those individuals who do have that infection, what's the profile that we're seeing? So what particular age groups are affected? Is it showing an ability to hurt people more than any of the other COVID variants? And it's early days yet for that, because we continue to look at our hospitalisations and our intensive care unit activity to see, is this going to be something which is or is not an issue for us? And it's too early for us to say at the moment whether the early information which we're seeing will translate into something which is more of an issue for the Scottish or the UK population.
I think for me what this emphasises more than anything is the ongoing need for vigilance and surveillance, not just across COVID and the way that virus inevitably will develop over time as well. We've seen it develop different characteristics over the 5 years that we've been aware of it. But actually across the broad respiratory pathogen network, to make sure that we've got robust mechanisms in Scotland of picking up any different patterns of disease presentation that we're seeing. And Public Health Scotland certainly have very good respiratory surveillance data, which is used extensively to kind of look at and see exactly what the emerging picture of infections across all the respiratory pathogens in Scotland is. But that surveillance data, you've mentioned it before about global surveillance. It's why global cooperation on the sharing of data is so important.
Let's assume for a moment maybe this or something else comes along next week or the next couple of weeks. What is our preparedness level like right now? So Greg, you spoke about PPE stocks and 12-week stocks, but what is it within them? Because as far as I was aware, the common mask that we use is sort of useless after about half an hour. So do we have enough stocks of real PPE to go out to GPs, to go out to social care workers, to go out to populations who are on the front line?
The short answer to that is yes. We have 12 weeks of stock, which is comparable to peak usage over at the point of the pandemic. So that exists just now in Scotland just now, and distribution mechanisms for that have all been developed. We've got scalable assets across Scotland, whether that be in medical equipment such as ICU. We've got the capacity to be able to double our ICU capacity if that was necessary. And we've got platforms which have been mothballed but kept under licence, and which can be brought back into play to allow us to develop not only the data but actually the infrastructure around about contact tracing at scale as well, if that were to be necessary. So there is scalable infrastructure in Scotland just now that, should something necessitate a wide response, that was able to happen.
And you spoke about data being king. Would it be helpful if we had a single IT platform across health and social care in Scotland to harvest data from?
So I can give you my view on that, and my view is that actually there are many reasons why a single digital platform that links data across, with appropriate access across health and social care and all the different sectors therein. I think there are tremendous advantages in that.
Question. Daniel, you spoke about harms that were caused. It wasn't just health harms, there's lots of other things. And I want to talk about lockdown and the harms that were done during lockdown when it came to our mental health. When we looked at way hospitals could not facilitate cancers, when we looked at schooling, and we looked at the harms that occurred to our children who went through school. With all those harms, and the evidence not, in my opinion, being great for lockdown itself, it was really vaccines, not lockdown. Where are we when it comes to potentially using lockdown again in a future pandemic scenario?
Just one of the things we didn't mention just on the variant, which we've no idea what this variant will do really at this moment, but obviously the other thing we would consider doing if it were a variant of COVID just now that was causing a threat would be vaccination again, because worth mentioning that we'd have that. The future use of social restrictions, I don't have an answer as to when you would wish to use them, because it's a political question. And I think the best you can say is, once you've understood the threat your society is facing, once you've characterised the severity of the disease, the profile of that, then you can begin to try and offer an analysis across the different considerations as to whether or not, I mean, you know, the withering effects of high social restrictions are uncontested, but you're putting them against, you don't have a good option. You're putting them against the potential impacts on, you know, if the disease profile is different, young people, you know, your ability to keep your society functioning. So I think those are just, by definition, questions for the disease and the politics of the day. It's just, I've nothing better to say about that. The more we can understand those longer-term impacts of what those social restrictions did, the better. And I think, for example, the very fact that we didn't know they could stop a flu, but they did, that's something we should learn from. But equally, the longer-term educational, social, economic impacts, we're still learning about those. So I don't have an answer as to whether or not we should use one again. You know, it's a question for the politicians of the day.
Yeah. Thank you.
Hawking. We can't hear you, Carol. You're on mute. Oh, you're now.
Oh, thank you. Yeah, you're unmuted by the. So, sorry. The UK's Inquiry's Module 1 report emphasises the importance of surge capacity in the NHS and how this was not planned for on the back of simulated exercises. Suppose my question is, given that the NHS and social care sectors were found to be unable to surge up at the onset of the pandemic, what extent do you think we could deal with this now, given that obviously after the pandemic we're still catching up? So just to give us an idea of where you think we are for that if we needed it in the future.
The efforts made by the NHS and social care across Scotland throughout the pandemic were nothing short of phenomenal. And the really significant sacrifice that staff made across all professions to make sure that people received the care that they required was really quite exceptional. But we can't rely on that as a response the next time, and we need to make sure that there is adequate planning in place for surge. No matter what the cause of that surge, and I think this is the point I want to bring out from earlier as well. We may need to surge the NHS in particular for all sorts of reasons, whether that be because of the emergence of a particularly bad flu or winter season, or whether that be because of a response to either a malicious attack or some of the global instability that we see abroad as well. So as part of the NHS's ability to be able to surge, there's a piece of work which the government is currently undertaking in the health resilience area, looking to see how they can work with our various health boards round about that surge planning and capacity. As I say, we already have the means to be able to surge in particular specialties just now, such as critical care, if that became necessary just now. There's no doubt about it. The NHS has never been so exceptionally busy as it is just now, and to work within the NHS is a difficult job for my colleagues just now because of the volume of very complex illness that they continue to see. Some of that is a consequence of our experience during the last 5 years, and particularly the pandemic. Some of that is just related to the changing patterns of disease that we see as we have an ageing population as well. But that surge planning is a key aspect and is underway as to how the NHS will respond in the future. And the kind of structures that we have within partnership between local authority and local government and the NHS in particular, and the resilience partnerships across Scotland also play a really key part in this, in ensuring that all assets within the community, across social care, across third sector organisations and across the statutory organisations are able to play their part in that.
Can I just say I'm really pleased to hear you talk about that resilience between the NHS and social care, because I think the pandemic really shone a light on how we have to get that relationship equal and importantly considered all the time. So do you think that there is enough work going on between Scottish Government, NHS boards and local government to see that were we to see a pandemic in the close future?
I can say to you that work is underway just now, and once it has had the ability to be able to proceed and particularly report findings and approaches, then I will be able to give you a more complete answer to your question.
That's helpful. Thank you very much.
Joe Fitzpatrick.
Thank you. Thanks, colleagues, and good to see you all. I want to go a little bit further in the area you touched on with Sandesh Gohani in relation to the WHO. Obviously, that was the suggestion of a pandemic agreement, international agreement, was first mooted back in 2021. It was just agreed by the World Health Assembly on the 20th of May this year. So it'd be good just to hear a bit more about what that means for Scotland, and if you wanted to put a pitch for why other countries should join it as well, that would be helpful, I think, to hear the benefits.
So let me state unequivocally, I think this is a good thing for Scotland, and for Scotland to be, although we don't have a direct relationship with WHO, our relationship is still strong through UK mechanisms, and it won't surprise you to know that the UK CMOs still spend a significant amount of time in discussion together, and particularly in sharing information and approaches as they relate to the WHO as well. So I welcome the Pandemic Accord and the update of the IHR, International Health Regulations, that sits alongside that as well. There's still work to be done, particularly around about pathogen sharing and so forth. That work will proceed over the course of the months ahead. But I think that this puts us in a significantly better position globally. I see the WHO as the organisation globally which is able to coordinate this type of response and to be able to ensure that the surveillance mechanisms on a global scale are present and working to be able to give us that early warning of any emerging potential threats that there are. Having the accord there, the legal basis upon which people will cooperate and share that information is an important aspect of that. And although it's been a long time in the making, it's taken over 3 years to negotiate through with member. I think the weight of support that you saw at the 78th World Health Assembly is really significant. Yes, I would absolutely wish that all countries in the world had signed up to it and continued to support the WHO. I think that it is a weakening of the global position for a country that is as significant and which has so much to offer in terms of its scientific basis as the United States has stepped away from the WHO. I think that is that does not enhance the capability of the WHO, and I would certainly, in my lifetime, hope that at some point will be reversed.
Jim.
Thank you very much. There's not very much more I can add on what CMO's offered, other than, of course, that this is a really very laudable approach that indeed all countries should be considering. Delighted that that accord is something which is in place. There's a component of that accord which is important for us, and it's that, of course, vaccine availability is critical whenever we have any new emerging threat, and ensuring that the most disadvantaged countries have access to a proportion of that global production is essential. Every developed country should be looking on that as an important aspect of what needs to be covered.
It's a really interesting point, actually, you've added just at the end of our questioning time. I see convener pushing in, but actually, I think, how can we get the message across? Maybe let Daniel have the last word here. That how important it is for all of us that the whole world works together, and we you know, health in Africa, for instance, is just as important to us here in Scotland as it is to people in Africa.
I can see in the convener's eyes my answer should be short, so I go back to something that was said during COVID by one of our scientific advisors, and it's a commonplace. It's no one is safe until everyone is safe. So anything that boosts the international rules-based order is a good thing for public health. How it's done is a second-order issue for me, but that's what we've been saying.
Thank you for your brevity there, Mr. Kleinberg. I'm a bit concerned that you can see into my eyes from that distance. But anyway, can I thank the panel for their evidence this morning? I think it's certainly given the committee a lot of food for thought and a lot of information about the work that's been done. Perhaps not as publicly as might have been. Before we were able to ask you about it. So I'll suspend the meeting briefly so that we can change witnesses. Thank you. Welcome back to the Health, Social Care and Sport Committee. The next item on our agenda is to undertake periodic scrutiny of the work of the Mental Welfare Commission for Scotland. And I welcome to the committee Claire Lamza, Executive Director of Nursing, Suzanne McGuinness, Executive Director of Social Work, and Julie Patterson, Executive Officer, Mental Welfare Commission for Scotland. And we'll move straight to questions, and Sandesh Gohani.
Thank you. And just a question of interest as a practising NHS GP. Thank you very much for coming in today. I want to start by discussing BBC disclosure. Given the serious concerns raised in this documentary, could the witnesses explain why issues were not identified, not acted upon earlier, and what action you believe is now needed to ensure failings are not repeated?
Thank you for that question. Absolutely. The documentary was hugely concerning. The experience of the 5 young people over that 7-year period was an awful watch, and to hear that experience. And you'll be aware the Mental Welfare Commission, we visited that setting over that 7-year period on 2 occasions on an unannounced basis. So in relation to those concerns, we are reflecting ourselves in terms of our work. As you know, we're not an inspectorate. We're not a regulator. We don't have powers in relation to closure of wards in the way that a regulator would have. Neither the care inspector can close care homes. We don't have those powers.
Forgive me, if you did have those powers, would that have made a difference?
We do require additional powers. Scottish Mental Health Law Review has stated that. However, our own reflection is that we could do things differently. So, as you know, when we visit services, we visit on a day. So it's a snapshot in time where we visit. Our focus is based on the laws, the AW Mental Health Act and the Adults with Capacity Act. Our duties and powers are in relation to those laws. And when we meet with people on the wards, we want to hear their experience. We want to hear what matters to them. We want to hear from families and carers as well as the staff on the ward as well. And we need to reflect and understand why some people don't feel able to speak to us when we visit. So not everybody speaks to us on the wards, because it's really important that we do have that range of views and experiences. So we have been reflecting on how do we engage with people more so, and young people in particular, and what we can do to do that. And that will potentially include not just being on a ward on a one-day basis, to be there on, have a greater presence on the ward, so that people get to know us and might feel more able to speak to us if we're there over 2 or 3 days, for example. So we're also reflecting on how can we engage with people who attend the ward too. So, for example, mental health officers who are social workers who work with young people and adults who are detained under Mental Health Act, and they visit routinely on the ward. So what can we do to engage with them more, to hear about their experience, about what they've witnessed, what they've seen? If they've had any concerns, how do they address them? How do they raise them? Because everybody has responsibilities in relation to child protection and adult protection. So we are reflecting on that, about how we can make our visits more enhanced rather than that snapshot in one day.
Okay. So you're reflecting. What have you reflected?
That is the reflection. We will start undertaking these enhanced visits to learn about the approach that we are planning to take to improve the work that we do. And I think it's been important to say that our functions are very much in law. We can't force people to speak to us. Part of the documentary, I think one young person said that they thought that was normal on that setting, so they didn't appreciate just how that experience should not have happened. So we need to do some more work about ensuring that children, young people, adults are aware of their rights in a care setting, so they know what's normal and what's not normal. So we do have work to do, and we have work to do collectively. So with those other professionals who attend the ward and visit the ward, for the staff on the ward, families, carers and the young people, we need to engage across the board and have a shared responsibility to do that. And we've got a responsibility to make sure we engage with all of those people.
Okay. And you're going to be visiting, but how do we ensure that we never get into a position where that type of abuse is happening? Because, it horrified me as a medic to see people being treated in this way by fellow professionals. So So what is needed to stop something like this from even beginning again?
I guess from Mental Welfare Commission's point of view, our roles and responsibilities extend beyond visiting. So we do visit, as I've just explained. We also provide advice and guidance in relation to best practice according to the law and what people can expect in relation to their rights being respected. We also undertake investigations, so where we are made aware of concerns, we'll investigate them at various levels, so it can be addressed locally, or we can lead to a 12-month investigation leading to a publication. We also have an advice and guidance line where people call us. We have about 3,500 to 4,000 calls each year, and these calls can be about advice and guidance about what people can expect from their care and treatment, or it can be about raising concerns about the care and treatment they're receiving, or families might raise those concerns, or professionals will raise concerns or ask questions. And from those calls, about 49% of those calls come from people who are using services or the carers' relatives. 51% of those calls come from staff working within mental health settings. And from that piece of work as well, we're able to highlight what concerns there are, and then that will inform our work too. So, for example, you may be aware of our authority discharge work in May 2021. And that came about because people raised concerns through our advice line to say that people were being moved from hospital to care homes unlawfully. So people who didn't have capacity to make decisions about moving to care home during COVID were moved unlawfully. We wouldn't have known that had people not contacted us on our telephone advice line. And then that led us to do the work that we did, and then led to the training programme for all staff in relation to AWI. So in terms of our work, there's a whole range of pieces of work that come together to try to mitigate any experience, as you described in Sky House, which, yes, we can only do our best in partnership with everybody else to make sure that experience cannot be repeated and learned from.
With the call line that you spoke about, did you receive any calls at all about Sky House?
I'm aware we received 1 or 2 calls in relation to individuals, and we picked these up and we addressed these with the service over the 7 years. And we work very much with individuals, but where we find there's a whole range of issues, then we will go in and do more detailed work. So not in relation to Sky House, we didn't, but there will be other areas of work where there's a wealth of information coming, where we will act and do more enhanced visits or more detailed visits.
How transparent is the process when it comes to looking at cases, looking at the investigations that are occurring, and the merit that has been taken to do this? Because if you have received calls about Sky House during those years, that raises a lot of concern, given what happened.
We receive individual calls by individual people, and we address these on an individual basis. Our focus is very much on individuals, not on services, but on individuals. So again, I direct you to our investigations in relation to, for example, Mr E, AB, Mrs F. So we focus on the individual circumstance of that person. Where there are a range of people, then it's more systemic, and that's something we would probably refer to another a regulator, for example. But in these circumstances, individuals, so our practitioners pick up the individual cases and they address them. And where they're not addressed, then they would raise them. But we do work with individuals at every level. And we have a number of individuals across a whole range of services across Scotland that we work with in the hope to address the circumstances for them. And that's our focus.
Okay. Thank you.
Declaration of interest. I'm an RMN. With current NMC registration, and I'm employed as a bank nurse by NHS Greater Glasgow and Clyde. You talked there about hearing, listening to views. You see a snapshot. You're looking at enhanced visits, but over that 7-year period, there was obviously very poor practice, if I can put it as mildly as that, within Sky House that Mental Welfare Commission appeared to be completely oblivious to. So what are you going to do to ensure that you do not miss that in other areas?
I think I'll pass to Claire just to talk a wee bit more about Sky House and the work that we did, and then I'll answer the question about what we're going to do in the future, if that's okay.
In response to the part about being oblivious, it goes back to what we say about that one-day snapshot that we're in. It's a visit day for those that don't or aren't aware. There may be 2, there may be 3 practitioners out of a group of 19 staff that cover the Mental Welfare Commission. They are knowledgeable, they are experienced, and experts in their field, so they wouldn't be oblivious. But the focus on that day with, if it's been announced, there will be people that have indicated they would want to speak to us. If it's unannounced, at that point, we would then maybe go around and find people that were willing to engage, if there were family there that were visiting. So a lot of the effort and the energy on the day of a visit is in terms of coordinating and getting those views on that particular day. In terms of sort of getting corroborative information, so the day we would maybe speak to staff, we would speak to the individuals that were happy to speak to us, family or carers that were there, and then after that we would have an opportunity to review their records. If during that 7-year period, what I've looked through and what I've found is that we've acknowledged that there are things that were going on and that were changes. So the early period, pre-pandemic, there were issues in terms of staffing, and across Scotland, the Commission has raised it repeatedly about some concerns we've had in terms of the use of agency and bank staff. That came through very strongly in those reports. Yes.
A point, because looking at what the committee papers, those terms seem to be interchangeable from Mental Welfare Commission, agency and bank staff, and they're completely different things. So are we talking about agency staff, or are we talking about bank staff, or are we talking about a combination of both?
Both, because both were used in the Sky House team, and what we highlighted at that point was at times there weren't enough staff, at times there were agency staff who didn't know the environment, at times there were bank staff who clearly knew the service but were maybe coming in, and if their numbers were down. So there were concerns in terms of the staffing. The other thing that's come through in our records and our reports is around about the complexity and the change of the group that were coming in, and we highlighted that in our last one where we said that Sky House were working on the model of care because they recognised that there were more young people with eating disorders, there were more young people with autism or ASD. So all the way through we've highlighted concerns, whether it's the staffing, whether it's the type of staff that's around, whether it's the model of care. The bit for the Commission, and we do it across all of our mainstream work, is that we would use recommendations. And the recommendations are to support how we would influence and challenge practice within the parameters that we have legally. And that's been our route, rather than requirements, rather than standards that we work to. So we have been aware of concerns, and we've raised them in the way that the Commission does through the processes, whether it's around what we've heard, whether it's around about use of the Mental Health Act or AWI, whether it's around about activities. So we've taken the intelligence that we've gathered on that one visit and used that, but we've used that repeatedly because the report for 2023 highlighted findings that we picked up in previous years, and I think we wrote that this has been something that we've raised in previous years rather than a one-off.
Get that, but what the Mental Welfare Commission didn't seem to pick up on was the malpractice that was occurring within the unit, despite the numerous visits and despite other issues being raised round about, which may have raised alarm bells. And you're saying that you make recommendations. Do you think that the Mental Welfare Commission needs more teeth?
Made recommendations repeatedly, and this is the bit that we've talked about in terms of reflecting on from our intelligence focus, and it ties in with the other work that's coming down from Sharing Intelligence Network and the work that's come through from a couple of, particularly the Scottish Mental Health Law Review and the Forensic Review, about the role of the Commission and what would be useful in terms of assurance and scrutiny and how that could be more robust. So there are bits of work that have made recommendations for how the Commission would move forward in that way. So yes, recommendations that we continue to have to repeat, because that is our that's how we've used the process that we have and the systems that we have up until now. Teeth to the point where we have the ability to use them would be useful.
Emma Harper.
Thanks, Convener. Good morning to you. Thanks for being here. We've kind of touched on some of the issues already. I mean, I will declare an interest, as I'm still a registered nurse also, although I'm a general nurse is my background and experience. I'm interested about the Scottish Mental Health Law Review. made some recommendations, and part of that was that, given that the Mental Welfare Commission doesn't have enforcement powers, and the convener's touched on it already a wee bit. So how does the Commission ensure that its recommendations from the visits lead to meaningful improvements in the service?
Yeah, just to answer that question, Ms Hawkey's question about do we need more teeth, yes is the answer. We do need more teeth. And I think your point exactly is that we are not a regulator. We don't have powers. We don't have powers to compel anything to happen. What we do, as Claire just explained, is we rely very heavily on our influence and our expertise, and that works to a certain extent, but there are areas where we need additional teeth, to deliver on these. And certainly that's come through Scottish Mental Health Law Review, which recommends that we do have more teeth. The Scottish Mental Health Law Review has been very clear about an extension of powers for the Mental Welfare Commission and a strengthening of our role. And that's based on 3 years of evidence gathering in relation to that review. And we very much welcome that. And we're really keen to see where those recommendations land and progress, because it does talk very clearly about practice that Ms Hawkey referred to there in relation to, for example, a chapter on coercion. And that chapter recommends a whole range of additional powers for the Commission. And that links to some of the practice that we heard about in relation to Sky House, in relation to use of restraint, for example. We would like to monitor and restrain more so across Scotland, because that's a key area where practice isn't currently monitored in the way that we would hope. So the Scottish Mental Health Law Review made 202 recommendations. A number of them are in relation to the Mental Welfare Commission, and we're really keen to see that progress, because we do think we need additional powers where we need them. At the minute, we do use our influence, and that works well. And in relation to the recommendations, Claire will give more detail, but we make recommendations whether that's an investigation report or whether that's a visit report. And we now publish the responses to our recommendations. We started doing that from 2021, so that we can evidence to the public that closing the loop of recommendations. So we had some feedback from people that we make recommendations, but so what? And so we started publishing our report to say, here's the so what, here's what the service has done in response to what we have said that we would do. And we follow up after 3 months of every visit, and we follow up after our investigation reports as well. And again, investigation reports, we didn't previously publish reports about what has been undertaken in response to investigations, but we started doing that as well, because it is really important, like you say, when we make recommendations, that people have confidence that action's been taken, and we can publicly share that too.
So just to go into Sky House, for instance, so there was 7 years that was part of this documentary, and then I guess I'm interested to know, like you've talked about unannounced visits and different visits, and how many visits does that mean, especially then if you're going back 3 months later to investigate, and are part of the visits speaking to the staff, the on-the-ground teams that are in each of the 3 ward areas, because I'm curious as to how it wasn't picked up earlier, the culture that seemed to have evolved into what was quite disturbing in the documentary.
So, absolutely. And just to clarify, we don't go back after 3 months. What we do is we provide a report with recommendations, and we expect a response and an action plan after 3 months. But I'll pass to Claire, who will explain exactly what we do on the ground for visits.
And it is that we start off with the day of the visit, and generally, particularly for Sky House, but most of the areas that we visit are known by the area coordinator. So there's already information and what we would look for intelligence prior to a visit. We've already spoken to the team, we've spoken to the senior charge nurse, nurse managers, we might have spoken to other members of the multi-professional team before we even visit, to get as much information as we can. The day of the visit is usually, like I say, there might be 2, there might be 3, there might be 4 members of staff. Sky House is a big service, so on any particular visit there may have been 3 or 4 individuals out there looking in a particular area. But if, like we were saying, unannounced at that point, you might not get the same number of people that would be willing to speak to us. and children and young people services, actually getting engagement on the one-day snapshot it can be almost as challenging as an adult acute ward where people are very unwell and may not necessarily know. There might be people in the ward that have no contact with the Commission because they're there of their own volition. So there's a whole range of things that might affect how we get the intelligence on that particular day. It may be, as Julie says, that there might be things from the information that's gathered of it for those individuals that we saw on that day. There may not have been the use of restraint or IM medication that we would then be following up, but if it was, we would have checked through that process. But fundamentally, what we build our report around about, if you see it, it's what we found when we speak to people. And the last report that we did in 2022, 2023, there were people saying that their experience was positive. So it's contingent over a number of factors of what happens on the day of that visit. But, and you'll see from some of our local visit reports, when we are concerned, when we do get the intelligence, either at the pre-visit or the day of the visit or post-visit follow-up information, which we would ask for, and at our feedback session, then we have an opportunity to confirm or get more details from that particular approach. We will then go back. We will then go back within that 6-month timescale, because there's the 3 months from the local visit to the report being published and the processes we have, and then there's a 3-month opportunity for the service to respond to the recommendations that we've made. And that's primarily where they do that on an action plan. So if we are and we do have concerns, then we would go back. It's from the Sky House one, as it was devastating for us to hear just how the level of distress of the young people that had come forward in the documentary. That hadn't been what we had heard on the visits. We'd heard concerning things about staffing, we'd heard concerning things about the different types of staff, we'd heard concerns about different approaches, but not to that extent.
So if you were to get more powers, what would you want?
I think the powers are very clear within the Scottish Mental Health Law Review. And as I say, that's based on 3 years of evidence gathering from people who use services, mental health services, their families, and various stakeholders, third sector partners within the community as well, and advocacy services too. So there's a whole range. There's clearly opportunities recommended in the Scottish Mental Health Law Review where we can take things to court if necessary. In the past, where we've needed to do that, we've gone to another partner for them to do that for us. So, for example, we did that with our partners in the Equality and Human Rights Commission, who took a matter to court for us to deliver on a concern that we had in relation to people's care and treatment. So we'd like to be able to do that ourselves. We'd also like additional powers, as I said, in relation to coercion, in relation to restraint, in relation to use of orders, the community compulsory treatment orders. We've done a piece of work in response to Scottish Mental Health Law Review where community compulsory treatment orders came in under this current Mental Health Act in 2003, came into being in 2005, and those orders were meant to be to support people to stay out of hospital, to recover at home and get well and come off the orders. But what we found was, and the Scottish Mental Health Law Review found, was people are on these orders for 17 years or more, and that's coercion in the community as well. So we need to look at how does that stop as well, because unless people are being supported to recover and to receive the service they're entitled to, they should not have orders in place to compel them to do things. So there's a whole range of things within the Scottish Mental Health Law Review that we would like those powers to extend our role so we could be more effective but also be resourced. So you'll know from our papers that we are small. We have a budget of around 4.6 million, so we do the best we can with the resources that we do have, but we would like to extend and expand based on what the Scottish Mental Health Law Review recommended.
Okay, thank you. Thanks, Convener.
Thank you. So I'd like to move on a wee bit on to another area of work that the Mental Welfare Commission has published a report on. You published the Hospitals Not Home report in January earlier this year. So I'd like to hear what your perspective is on the effectiveness of the Dynamic Support Register in improving visibility and transition planning for individuals with learning disabilities.
Yep. So, thank you, Ms Hawkey. I mean, the Hospital Not Home report was a piece of work commissioned by the Scottish Government in particular in relation to the lack of progress or apparent progress in relation to coming home. I think we're very clear at the Mental Welfare Commission excuse me, that people should not be in hospital unless there's a clinical need for them to be there. It's not the right place for people to be, excuse me. And we were concerned when Public Health Scotland reported that there were, at that point in time, 30 people in hospital for 10 years or more. And when the Mental Welfare Commission contacted all health and social care partnerships to ask who was on the Dynamic Support Register, it was 55 people between, and that was within 4 months of the Public Health Scotland figures. So the numbers are growing. And as you rightly say, we focused on these people who had been in hospital for 10 years or more, and some on average 18 years, those 55 people. And we're really, really quite concerned about the lack of movement, lack of dynamic support planning, despite the Dynamic Support Register. And despite delayed discharge planning, which is, quite a significant industry in health and social care partnerships who really focus on delayed discharge. Yet there's still people with learning disability complex needs and people with mental health conditions stuck in hospital. And what we found was it's early days in relation to Dynamic Support Register and early days in relation to the peer support network, again set up through Coming Home report, which I think I first met in October 2024. So it is early days yet. And there is hope for those two aspects because the peer support network is so important. What we identified was that there are people getting stuck in hospital because they've got very, very complex needs. But if there's a national strategic overview where there is really good practice in some areas, and if that good practice could be shared nationally, then creative solutions can be developed in communities because they do exist. It's just that some areas don't know about them. So that peer support network can have the potential to make a significant difference. The Dynamic Support Register so far is quite inconsistent, we found. It was unclear about who would end up on the Dynamic Support Register and who would not. And likewise, delayed discharges. Sometimes it was hard to know who would be on those lists. And probably more worrying is there are people who are not on any list, and they should be. And we were really quite concerned by that because there are people who were almost lost and hidden. And sometimes the view if somebody was an older person, then they might stay in hospital because there was no exit strategy. But these people also have a right not to stay in hospital and not to be in hospital if there's no clinical need. So we also found there's a lack of dynamic care planning as well for some of these people. And that dynamic look at services rather than thinking it's person's got very complex needs, we can't create something because it's too expensive, because it could be more cost effective if it was done as part of the peer support network. And I guess Hospital Is Not Home report highlighted all of these things, but it followed our out of NHS placement report as well. Very similar themes in relation to that. And again, I'll maybe pass to Claire in relation to that, where we found that people were placed out with NHS Scotland and sometimes forgotten about because they're in England or private settings. And again, they have a right not to be there either. But as soon as they're out of NHS Scotland, then their care teams or the host authority sometimes didn't maintain contact and people would stay there.
So in terms then of, and we might move on to that a bit further, in terms of the effectiveness, do you think that the register is effective or not?
Sorry, the register it's early days. I think at the minute it's not as effective it could be because it's so inconsistent in terms of who's on that register and who's not on that register. And likewise, the Peer Support Network, which is a recommendation of Coming Home, that only set up in October 24. So I think there's time for that to improve. It clearly can make a difference and will make a difference if that coordination is in place. And as I say, we recognise health and social care partnerships are extremely busy. They're very, very busy on the day-to-day work. And it's really quite difficult to look to your fellow health and social care partnership or one quite far away to find out whether some people have similar complex needs and that they could create a creative solution together. But the peer support network will allow that. And as I say, there are really good examples of creative solutions in the community, but just not everybody knows about them. So that peer support network could make a huge difference. So I think what I'd say is the potential is there. When we did this work, it hasn't quite been realised, but it has the potential.
So when you're talking about a peer support network here, are you talking about interagency working and looking at best practice in particular parts of the country, particular local authorities or whatever?
Absolutely.
As opposed to peer-to-peer?
Yeah,
Okay.
absolutely. Because often peer-to-peer, you're right, it's people with experience that share that experience, that lived experience. But this peer support network, as recommended by Coming Home, is partnerships, agencies working together to create creative solutions locally for people.
And is the Mental Welfare Commission involved in that ongoing work?
The Mental Welfare Commission is involved in relation to the 55 people in the Hospital Not Home.
No, in terms of the developing best practice and that sharing of best practice?
No, we're not.
No. Okay. No. Is that because you weren't invited to it or because you've chosen not to participate?
We've not been invited to the peer network support. I guess the best people that know what the needs are locally in terms of that commissioning, that national strategic commissioning, are the commissioners from across health and social care partnerships. What we would then do as a Mental Welfare Commission is visit people in these creative solutions that are developed in the community to be assured that the care and treatment is lawful and according to the work, the standards that we would expect based on best practice.
Okay. So what improvements do you feel are required to ensure that individuals with learning disabilities and mental health needs who are clinically assessed as being ready for discharge, how they can be helped to transition effectively into community settings? I don't know if maybe Ms McGuinness would like to contribute.
I'll maybe start by, I think the report out of NHS area report highlighted that millions of pounds are being spent across the board in relation to people who are out of NHS placements. And if there's a strategic overview over that financial envelope to create something more locally, that would make a difference to help people's transition quicker in a more coordinated way to more local areas within Scotland. But I'll pass to Suzanne in relation to particularly the social care aspect of it.
Yeah. Thank you. Yeah, in terms of improvements, I think as Julie has said, there is a lot across the piece at the moment. A lot of barriers, a lot of challenges that services are facing, and we see that through our work. And in terms of assessing and people being ready for discharge, particularly people affected by learning disability, it's about earlier intervention, and it's about planning, it's about discharge planning, and it's about the right resources being in place in the right place at the right time for people. That's that's the fundamental of improving the outcomes for people.
Okay, so what improvements need to be made? I think we all accept that those things need to be in place, but obviously, as a commission, you're saying improvements need to be made here. So what improvements need to be made?
There's a lot of improvements that need to be made. In terms of joined up, there's a lot of work going on right now, as in the coming home agenda, etc. In terms of that, you're looking at additional resource. I think Claire's out of, for example, Claire's conducted a piece of work on the out of NHS Scotland placements and found a very, very conservative estimate of a cost of 13 million through NHS funding for, I think it was 59 individuals. Which is a lot, and that is very conservative in terms of you're looking at that funding and looking at, and everybody can join in that. Julie's talking about the peer support network. Everybody can join in up and looking at how can we do things differently and be creative and innovative now. We also, as part of our role, we also hold end-of-year meetings across every health and social care partnership, every health board, and we do hear some pockets of services trying really hard to be innovative and creative, but resources are limited in terms of what they can do. But it is about them having the time and the space and space to share that best practice, because they are local and they are best placed to decide what is best for the people in their areas.
So, but does the Mental Welfare Commission have a view other than increased resources and some of that sharing best practice about what improvements need to be made?
Can I answer? It starts, and it probably aligns with what we were saying about Sky House in terms of the intelligence. And one of the things that Julie highlighted in terms of the coming home and the follow-up and the information that we collected in Hospitals Not Home replicated in the out of NHS was that information that's given through to PHS, who then collect it, who we then use that data and then get further information on it, that data's not always accurate. It's gathered differently. Delayed discharges are gathered differently across Scotland. So what we're looking for, and it comes back to that bit that Julie was saying about the standardised approaches that need to be taken, which again would be through Scottish Government and the recommendations that we made at that point. So at the core, if the information's correct, we then have the authority and the ability to follow that the way we did with authority to discharge. It gives us the intelligence and information to check what's happening in the local area, as Suzanne was saying, through either our area coordinators, through either our end-of-year processes. So we do, if we get the information correct, we can then follow up either through the individual or through the health and social care partnerships and our links with them. But it comes back from being able to know that what we've got is accurate. And at the moment, we're not sure that it is that accurate. So if you go back to the register, what we found, as we'd asked with the 55 people, as we did with the NHS, was it's not always collected systematically across Scotland and provided in a way that can then be followed up to the point that we would want it to be done. And then we can give that information back to the areas and the partnerships and say, what are you putting in place here in terms of further community resources? What are you doing in terms of discharge planning? So it's a progressive continuum that has to happen, but it has to happen with getting the right information and being able, and for us as a commission, being able to access that and then the resources to be able to follow that through.
So it be data, or better collection of data, increased finances. Mental Welfare Commission has no other recommendations for how we can help people with complex needs transition to community safety or community places safely. Julie?
Can I just add to what Claire said? In relation to our work, I think we've highlighted a range of improvements that are required. So, for example, from our Mrs F report, huge concerns in relation to the distressing events in relation to that particular death, where there's a lack of understanding and grasping of the importance of communicating with families and relatives and taking on board their views. Also highlighted a lack of understanding about risk. So clearly identified improvements required there, which not only in that area but across Scotland as well. When we do a piece of work like investigations, we recognise the learnings across Scotland. Mr E likewise, where Mr E, the improvements identified were that health and social work did not work together. So Mr E fell between. So health thought social work were responsible and social work thought health. And the teams were very clear that there was not an integrated approach, despite that intention being that.
So that discharge from hospital?
Pardon me?
That delayed discharge from hospital into a community setting?
This case wasn't in relation to delayed discharge. It was...
Sorry, I'm trying to. I'm perhaps not being clear enough. But I'm looking specifically at what Mental Welfare Commission recommends to help transition people with complex needs from community settings into community settings safely, people who are clinically ready for discharge. So you've identified two areas of data and finance. Is there anything else that the Mental Welfare Commission would specifically recommend that would help to facilitate that?
Absolutely. We've already recommended AWI reform is really important. AWI is a clunky piece of legislation now. 20 years ago it was of its day, but now it's really quite clunky, and sometimes it prevents people from being able to move from hospital to the community. But rightly so, because the safeguarding legislation should be respected, but it could be less clunky. So that's a key area. So we look forward to the AWI reform that's progressing. Access to social care is really, really important, and the right social care, recognising that there's a range of partners who can provide that social care. Third sector partners are expert in relation to providing social care and rehabilitation in the community that doesn't have to happen in the hospital. So that's really important as well. And I guess advocacy is really important. Advocacy is critically important to support people's voices to be heard, particularly people we're talking about who often their voices are not heard and they need some support, and they may feel disempowered in hospital settings, and their health condition may be that they don't have the confidence to speak. So advocacy is so important, and we're particularly concerned that we hear that in the current fiscal environment that advocacy, rather than being grown, individual advocacy and collective advocacy may diminish. So that's a huge concern. That's something that we would see as a concern if that wasn't in place for children, adults and older people, to make sure that people's views are heard, to support them to move out with hospital to where they want to go in a setting that's important to them.
Thank you. David Torrance.
Thank you, Convener. Good morning to witnesses. What do the witnesses think in the progress to date of implementing the recommendations in the Mental Health Law Review? What progress has been made? Let's be open and honest about it.
I think you probably have spoken at length about that. Scottish Mental Health Law Review, we really welcomed that law review because both the Mental Health Act and AWI Act, as I say, were of their day back in the day, but they're decades old now. They've not kept up with human rights, and we need that reform. So very keen for the recommendations. We recognise the 202 recommendations in the Scottish Mental Health Law Review. We recognise that some will take perhaps up to 10 years to be realised, but others don't necessarily need changes in law and recommendations can be acted on, and others can be done much more quickly. So from our point of view, from the Mental Welfare Commission's point of view, as I've said previously, there's a number of recommendations that we would really like to progress or have considered in relation to our roles and our role and responsibilities to strengthen that and to grow our impact and make us more effective. So we are really keen for the recommendations to be considered and, if agreed, to be implemented at the earliest opportunity.
Thank you, Convener. I have no further questions because the other ones have been answered.
No problem. And Paul Sweeney.
Thank you, Convener, and thank you to the panel for joining us today. Just really want to touch on the wider issues of key challenges to mental health services. I think the Convener already touched on some of the complex cases and been able to deal with those. What measures do to improve care within Scotland's mental health system for individuals with complex needs?
Mr. Sweeney, we lost you for a minute there. Could you maybe repeat your question? We lost a part of your question.
Apologies, Convener. To repeat my point, I'm just keen to know what measures the witnesses feel should be taken to improve care within Scotland's mental health system for those with complex needs, including autism, acquired brain injuries, personality disorders and dual diagnoses.
Thank you, Mr. Sweeney. I think what you describe is the work of the Mental Welfare Commission. So I think we're very clear that population mental health and wellbeing is absolutely important, no doubt about that. However, from the Mental Welfare Commission's point of view, our concern is for those people at the end of the mental health continuum where those people who are experiencing severe and enduring mental illnesses. You reference acquired brain injury. It's people who have not got the voices sometimes in the way that other people are able to express their views. So these are the people that are most important to the Mental Welfare Commission because we know they are some of the most vulnerable people in our society. So that is the group of people that you describe, which is our focus, and that's the group of people where we need to ensure that their rights are upheld, their rights are protected, and that we, with services, can support them to do that. So throughout the work that we just described previously, through our visits, through our individual visits to people in their homes, in care home settings, in health settings, that is the group of people that we focus on. And you will have noted our previous work in relation to alcohol-related brain damage. We did a piece of work where we visited a number of people with alcohol-related brain damage to identify their care and treatment. Was it appropriate? Was there recognition that people with ARBD can improve their skills and abilities and not necessarily require legislation to compel that? So that is our focus from the Mental Welfare Commission.
It seems to me that there are fundamental problems in relation to resourcing that have been identified in its 2023 report. In Adult Mental Health, Audit Scotland noted that limited and short-term funding across many mental health services are creating additional challenges in addressing staff recruitment issues. So this makes it very difficult to fill vacancies because funding is often provided only on a fixed-term basis, which is very undesirable to applicants. I think we've seen that play out, for example, in relation to not just third-party services, but also core services like Sky House, where a culture of high staff turnover, lack of leadership was identified as a key causal factor in the poor performance of that unit. Just wonder what long-term strategies are needed to address that short-termism and to deal with the resultant issues with staff recruitment and retention currently being experienced across pretty much all aspects of Scotland's mental health system.
You're absolutely right. We, obviously, as Suzanne has just said, we meet with health and social care partnerships annually with most senior managers, and we do our regular day-to-day visits, as Claire described, speaking to nursing staff, medical staff, social work staff on the ground. There's a significant challenge in terms of staffing across the board, whether that's nursing, medical staff, mental health officers, and that impacts upon the care and treatment of the people that are most vulnerable. So without mental health officers, then that's a really important safeguard for people. Not having enough nurses or medical staff can lead to, as Claire's described, bank agency, we know it's different, but it's still staff that are not substantive within the setting. Local medical staff that can lead to lack of consistency of care, lack of continuity of care, because there's such a demand on the services. And as Claire said, the level of acuity is increasing, and our staff group isn't increasing to match that. So they are clear areas that are reported to us where it's a challenge, and we need to appreciate that when we're visiting services, because we need to understand that context as well. And likewise, the funding that you described, we hear from third sector providers in particular about the annual funding, the lack of ability to plan, the desire to have at least a 3-year plan so they can plan ahead and not have the fixed annual funding. So we know there's significant challenges across the board. We know, as I've referred to advocacy as well, it's really, really important for the people that you described, the people who are most vulnerable, and we do need to have sustainable services. And I guess from Mental Welfare Commission point of view, we visit, we make recommendations, we focus on the individuals and their experience, but we do hear from the services, from those commissioners, about the challenges in relation to providing services that we expect them to provide for the people who are most vulnerable. And the law says that they have a right to those level of services, including in Section 25-27 of the Mental Health Act, is the right of access to assessment for social care services to support people to leave hospital.
I think the point was hinted there. You mentioned health and social care partnerships, integration joint boards, and certainly it seems every financial year there are decisions made at that level which militate against long-term value creation in the mental health services in Scotland. I could rhyme off a number of recent decisions, for example, in Glasgow around Flourish House, for example, Notre Dame and the Sandyford, that don't really chime with the objectives that are being set nationally. There does seem to be an issue about fragmentation and lack of accountability across the system to design services that are focused on the needs of patients' delivery. To turn to recommendations, what do you think we need to do to improve that structure around poor data collection, lack of coordination, and a lack of accountability?
I guess as a Mental Welfare Commissioner, our focus is very much on the individual needs of the people that we're working with. So we're focused very much on individuals. We're not an inspector of services, as I said before. We don't regulate services, but we do hear the stories that you've just described from the people that we meet with from services about the challenges they have, because they are absolutely interlinked. When we're asking for the highest possible care and continuous care, continuity of care for people, then we do hear about the challenges as well in relation to finances, in relation to funding. But I guess our job at Mental Welfare Commission is to be aware of that, but never to lose focus on the individuals and the care and treatment that they're entitled to according to the law. So we appreciate the challenges, and we appreciate that the decisions about funding, about structures, about organisations sit out with the Commission. That's not for us to dictate how people fund or what they provide, but we do know what services people need in order to live and flourish. People who have mental health issues, learning disabilities and associated conditions have a right to live the lives of their choosing and to flourish and to have the support to do that, and we'll continue to raise that.
I suppose just in terms of themes that you gather from individual experience, there will be commonality that perhaps drives towards instinctive recommendations. Is there any insights you have aggregating patient experience that you see these common trends, common relationships that would make you consider what needs to change? Is that something that you could maybe offer some personal insight on at least?
I think when we make recommendations, I'll talk from local visit, we make over 450 recommendations of our local visits. The theme seems to be fairly stable across the times that I've looked at these, and most of the times it's about people feeling engaged and having meaningful contact with whoever's delivering that service, even when in terms of their care planning, in terms of, we've talked about discharge planning and people being involved in what happens to them. It's in terms of what restrictions are put in place that they maybe don't understand or don't agree with. So there are a number of things that people feel are being done to them, but you know, that the care provider or the individual who's being cared for, or their families and carers, because the other thing that we hear how often is families and carers are not included in decisions made about what happens to someone's future, where they go to, what will be available for them, what will be on offer for them. So the themes remain pretty consistent in that individuals that we speak to would like to be more would like to be heard, they would like their rights met in terms of what happens when they're receiving care and treatment. They would like access to a broader range of, it might be AHP, psychology, all of that picked up very clearly in the Audit Scotland report, I saw that. But it's also activities within their own community that are meaningful for them, that give them the life that they would find that would be beneficial to them, that Suzanne's highlighted. And environment's another thing that seems to be something that's come through and that's it's had an impact over the last few years, is that a lot of the environments that people in mental health or learning disability services are getting or can access are not fit for purpose. So there's a number of challenges that people repeatedly raise with us that I think are consistent, but mostly it's around about I would like to be heard, I would like to be involved, and that's from individuals and their families and carers.
That's helpful. I appreciate your time. Thank you.
Thank you, Mr Sweeney. Emma Harper.
Thank you, Convener. Just some thoughts about the work that I've done previously about eating disorders, and I know the Mental Welfare Commission had did a mapping exercise of eating disorder services in Scotland. I know we've seen an increase in the number of people assessed and then diagnosed with eating disorders during COVID, and that obviously is something that, you know, we've had lots of discussions, and there's been additional funding from the Scottish Government, and the eating disorder charity BEAT have been really good in engaging and supporting with their activities online and things like that. So I'd be interested to hear about any updates on any from the mapping exercise or any recommendations, and this is something that you would say needs to be a #1 priority in referrals, for instance, because of the eating disorder services that we have across Scotland. And like, for instance, in Dumfries and Galloway in the Borders, they've got on-the-ground specialists, but then sometimes need to be referred to Skye House, for instance. So just an update about that.
I'm happy to pick that. Because, again, it comes back to the role of the Commission, so it would be the individual or young people or adults with probably the most acute experience of an eating disorder that require that secondary care that would come into contact with the Commission. They may contact the advice line, it may come through in terms of casework, and at that point we would advise accordingly for organisations like BEAT, who helped us when we were doing the eating disorders. So that part of from what happens in community-based services, those would be the people that we would make the links with to anybody that contacted us or asked us. The other side of that, in terms of the more extensive requirements for somebody that has complex eating disorders at whatever age, those are the ones that we do more focused work on in terms of what we've done. So the mapping exercise, our contact with services like the Regional Eating Disorder Unit and our visits to that, and the other, its equivalent in Glasgow, allows us to have the understanding of what's happening in terms of the guidelines, sign guidelines, how these are being implemented, how that's then working, because again, I'm aware of tiers with the eating disorder service that sometimes tier 4 or however they work it, and then it hands on to the community-based services. So we remain and retain an overarching understanding, but are primarily focused on when someone is admitted to an environment where they're getting care and treatment, and it comes back to what I was saying to Mr Sweeney, at that point our interest is, has that individual, have their rights been, have they been made aware of their rights, have they been encouraged to develop other strategies and contact other organisations, do they have access to all of the right care and treatments, dietetics, occupational therapy, psychology. So it's that part that we would do more specifically rather than an overarching focus in terms of what's happening in eating disorders across the piece.
And just before you come in, Julia, I know that there would obviously be issues around transitioning from inpatient to community in supporting young people, because it's boys and girls as well. It's not just everybody thinks they're girls, but it's not. So I'm interested in the community aspect as well. Sorry for interrupting.
No, thank you. Just want to add to what Claire said there. We've just issued this month, or last month, May, our updated guidance in relation to eating disorders, so I have to send you a copy of that as well. And just your point, in terms of the work that we do, we have an advisory committee which includes a whole range of people with experience of using services. It's a statutory committee of the Mental Welfare Commission, so they tell us what's important in terms of the work that we should be doing for the next business year. So our eating disorders work would have come from that suggestion, and we take suggestions from across Scotland about what should our focus be, because we only know, as Claire says, we only know what's important to people if they tell us that. So it might be something, if there's an area like eating disorders which might raise again because of the work we're doing in children and young people's units, that we need to do more in relation to that and more learning across the board. So that may well be something that comes out of that going forward.
That's it, thanks.
And Stephanie Callaghan. Ms Callaghan? It doesn't appear that she's there.
Thanks, convener. Sorry, I couldn't take my mute off there. We touched on families earlier on, and how very often patients are actually quite ill, and it can be quite difficult to get information, which makes families all the much more important. Often families are the people that know the individuals best and have the strongest desire to ensure their well-being and get them home as quickly as possible. So I'm wondering if you feel that there's a need for actually formalising family involvement, having structured interviews and recording and reviewing what families are saying, or in any other suggestions that would involve listening to and acting on what families have to say. Thanks.
Broadcasting. I think your camera must be off, Ms Callaghan.
Can I respond?
My camera's on.
Might need to sit forward.
Thank you. Your time is perfect, Ms Callaghan. We've just completed our first themed visit working with carers, and it's been useful in terms of we have a process at the Commission. I think we provided it in the documents about our advisory committee, and the advisory committee highlighted exactly what you've picked up, which is hearing the voice of families, relatives, carers, unpaid carers, and that whole collective terminology. So we have we consulted with a range of carer organisations, similar to how we did with the eating disorders process or a theme visit, as we do, and we're about to, we've got their views, so we're in the process of pulling that together, and we'd hope fairly soon to have a series of recommendations that come from that work and the findings that we've heard. I think it probably is a bit fair to say that some of the stuff that's come through is fairly shocking for us as well. It's distressing to hear the experience that carers have had and some of the difficulties they've seen with their loved ones and the care and treatment that's been provided and that they've not been informed about. And I think one of the things that we did in our guidance, we recently updated carers' consent and confidentiality, which again highlighted some of the concerns that carers have repeatedly raised with us through our advice line, through our contacts on visits, through our investigations. We've talked about Mrs F. So we constantly have a contact and an understanding of some of these issues, and hopefully that will come through in the team visit.
Thank you.
Thank you. Can I thank the panel for their attendance today and for your evidence? The committee is going to continue its work, but please feel free to leave. The fourth item on our agenda today is further consideration of the following negative instrument, the Human Tissue Supply of Information about Transplants Scotland Regulations 2025. The purpose of this instrument is to create a duty for relevant clinicians to notify the Human Tissue Authority if they are made aware that their patient has received a transplant outside the United Kingdom, or have a reasonable suspicion that specified offences under human tissue or modern slavery legislation may have been committed. The Delegated Powers and Law Reform Committee considered the instrument at its meeting on the 13th of May 2025 and made no recommendations in relation to the instrument. No motion to annul has been received in relation to this instrument. The committee considered the instrument at its meeting on the 20th of May and decided to write to the Minister for Public Health and Women's Health to request additional information in relation to the instrument. The committee received a response from the Minister on the 27th of May, and this has been published on the committee's web pages. Do members have any comments? No. I propose that the committee does not make any recommendations in relation to this negative instrument. Does any member disagree with this? No. At next week's meeting, we will undertake periodic scrutiny of the work of the Care Inspectorate, as well as taking evidence from representatives of Food Standards Scotland, and that concludes the public part of our meeting today.